So before going on to aorta, is a very important thing that we should discuss the zones of aorta. There are 6 zones of aorta. We can see in the picture. This is zone 1, zone 2 and zone 3. Up to zone 3, this is the ascending aorta, and zone 4 and zone 5 is the arch, and zone 6 is the descending aorta. So zone 1 is the site for aortic suture during aortic valve replacement. Zone 2 is the site for proximal grafting during CABG. Zone 3 is the site for aortic cannulation, cardioplegia cannulation and the cross clamp. And aortic cannulation might sometimes go into higher up in zone 4 also. So zone 4 and 5 is actually arch, and zone 6 is the tip, is the importance is the tip of the IBP is up to kept in zone 6. Is the descending aorta. As for the 2013 guideline, there are 11 views of thoracic aorta. The red marked are the specific for the aorta, and the rest of the views are associated with the other structures that are shared with the aorta. There is mid-esophageal ascending aorta long axis view, mid-esophageal ascending aorta short axis view, descending aorta short axis, descending aorta long axis, upper esophageal arch long axis and upper esophageal arch short axis. So what are the limitations of TE? At first, because of poor visibility, this part is the invisible part of the aorta, ascending aorta, and this is the almost poorly visible part of the arch due to the interposing trachea and the right bronchus. So that is how we do the epi-aortic scanning for the for finding any thrombosis there or not in the. This is a actually 15 Hz probe put on this, and the water is used as a medium in between, and you can see the short axis image of the ascending aorta. And another thing we can do is the A-view catheter to used along with this TE probe, where we put a balloon-like thing and we put in the bronchus and put a saline so that the air interface does not come in between the TE probe and the heart. And another thing, the limitations of TE is the reverberation artifacts because of the two strong reflectors, the anterior and the posterior wall. Both the walls are strong reflectors, producing much of a reverberation artifacts. That sometimes this is your ascending aorta, and this is the reverberation artifact due to this posterior wall of the pulmonary artery, that is RPA, and also the oblique and off-axis imaging occurs in the aorta if we do not cut it in the same plane, because if you in a long axis view you can see the problem of off-axis imaging, that your aorta diameter significantly changes in both in the long axis and the short axis. So the CATS grading, the aortic atheroma grading, grade 1, grade 2, grade 3, grade 4 and grade 5, we can see in the image. It's a descending thoracic aorta, is a mobile plaque. So any plaque, whatever be the size, if it is a mobile, it is a grade 5. There are various other gradings also, but the most common these are CATS grading is it's followed. This was the actually question came in the last time theory exam. So intimal thickening without protrusion into lumen is a grade 2, and plaque protrudes less than 5 mm into aortic lumen is grade 3. More than 5 into aortic lumen is grade 4, but up to 1 to 4, these are all non-mobile. If the plug becomes mobile, it will become grade 5, whatever be the size. Now the aortic aneurysm, it is a Crawford aneurysm classification. This also commonly asked, what are the classification for the aortic aneurysm. So there's a 5 types of classifications of Crawford. That it is actually descending thoracic aorta aneurysm classification, where your sixth rib, your diaphragm and your renal artery, these 3 things are forms the boundary for the each divisions. There is one involves your from above the sixth rib up to the crossing the diaphragm, but before the renal artery, whereas 2, it involves the abdominal aorta and the thoracic aorta as well. 3, it involves the abdominal aorta only, but it originates just above diaphragm, and 4 is completely subdiaphragmatic, and 5 just involves the subdiaphragmatic and supradiaphragmatic part. Now, role of the TEE in aortic arch and DTE aneurysm. There is a correct positioning of cannulas for peripheral CPB and confirmation of LA cannulation for left heart bypass. In the case of left heart bypass, that we just send the blood from the left atrium, take the blood and put it in the distal part of the your aneurysm, where the clamp has been placed, distal to that. And the monitoring development of AR and ventricular dilatation, because at the ventricle is acting on a crossed clamp condition at that time. So ventricular dilatation, that is LV dilatation, is very common at that time, and monitoring of LV filling and RV function as well. Okay. Now, adequacy of the proper landing zone of the stent graft, confirming absence of atheroma calcification at landing zone, and confirming absence of endoleak. Endoleak means that there is a leak between the your stent and between the true sac. So if you see the swirling echo contrast in aneurysmal sac, that means endoleak is there. But if there is a static contrast, but the contrast is not moving, that means there is a proper exclusion of the aneurysmal sac. This is a video of showing the sinus of Valsalva and aneurysm. So this is a connection between your aorta and your RVOT. You can see that is a sinus of Valsalva aneurysm. Now the aortic dissection. Aortic dissection, 2 types of classifications commonly asked. There is a Stanford type A, type B, and DeBakey classification. So DeBakey type 1, type 2 and type 3, and Stanford type A and type B. Stanford type A and type B is actually very simple to remember. That Stanford type A means your ascending aorta is involved. Stanford type B is ascending aorta is not involved. That's all. And in the DeBakey is a type 1, it originates in the ascending aorta and it propagates through at least through the aortic arch and often beyond distally. Type 2, it is confined only to the ascending aorta, and type 3 is the only descending aorta is involved. So hallmark finding of acute aortic dissection on TE is a visualization of the intimal flap. So dissection flap motion is independent of surrounding structure. That's how you will get to identify what is the dissection flap, because many a times reverberation artifacts looks like a dissection flap. So dissection flap actually moves with the independent of the other surrounding structures. And colored Doppler flow also shows differential flow on each side of the flap. I'll come to later. So this is a mid-esophageal ascending aorta long axis. This is a type A dissection that is involving ascending aorta. So this is a dissection flap. It is coming into the LVOT and the LV cavity. And this is another patient. And this is the mid-esophageal ascending aorta short axis view, where you can see that this is the dissection flap. But more important is that this part is your true lumen and this is your false lumen, because by putting the colored Doppler you can see that there is a flow across that. So descending thoracic aorta short axis, the type B dissection, you can see that this is a short axis view, and this is the small lumen. The smaller lumen is actually the true lumen and the larger lumen is actually the false lumen. So how to identify, and this is also the long axis view of the descending thoracic aorta long axis, showing the type B dissection, and there are multiple small puncture sites also we can see. So how to identify which is true lumen and which is false lumen? Number one is LV ejects into true lumen. So that is why it is expands during systole, and it's also circular in short axis during systole, and it collapses on the diastole. And it's just the opposite in case of the false lumen. It is crescent shaped in short axis, and it is smaller in diastole, smaller in systole, and expands in diastole. And it is also often smaller than the false lumen that we can see in the image, and it is a spontaneous echo contrast can be seen in the 2D, and normal flow pattern in the colored Doppler in true lumen, and the false lumen reduced or sluggish flow on the color flow Doppler. Now, what is the difference between the aortic dissection and your intramural hematoma? The most important dissection is that there is no false lumen, entry tear or dissection flap. What happens here? Here the blood collects in the media, but there is no intimal tear. So there is a rupture of the vasa vasorum, that is the vessels of the aortic wall, and they form a hematoma inside the wall, but without breaching the intima. So this is a precursor of the dissection. If we get in an echo the thickened aortic wall more than 7 mm, then that is a sign of there is a aortic intramural hematoma. These are intramural echolucent areas also when the blood gets reabsorbed. So there is no false lumen or entry tear or dissection flap is seen. Now this is a case of the penetrating atherosclerotic ulcer. So how to know that it is a penetrating atherosclerotic ulcer? Because the luminal wall is actually jagged, and it is, you can see a focal ulcer, because the aortic wall should be very smooth, but it is jagged, and here is a focal ulcer, the outpouching of the aortic wall, and you can see the flow across it. Now the most important part of this question came on two times in the last exam. This the positioning of the IVP catheter, the optimal positioning. The optimal positioning should be this 2 cm below the left subclavian origin, or if you cannot see the left subclavian, at least at the lower edge of your ascending aorta, arch. If you draw a line, and that is the optimum position of this IVP catheter. So IVP catheter, there is a balloon tip, and it should be positioned, and during diastole you can see that there is an inflated balloon, and there is a balloon tip, whereas in the systole the balloon is deflated, so you can see only the catheter and its tip. It's over for the aorta.